Hello, once again, to my subscribers, my dear friends, fellow nurses, colleagues, and students. Yes, I'm back. This is your mentor, your fact check buddy, Ray Gapus version 2.0. As you could actually see, the title of my comeback video, the Ray Gapus COVID experience. This is part one of three, how I survived critical COVID pneumonia. And you would say, how and what and why, and all sorts of questions. I had the same feeling. And the very reason why I sort of hibernated for a couple of months was that I really went through the agony of critical COVID pneumonia suffering. And at this point in time, I'd like to translate that near-death experience into something that would fuse scientific facts with experience such that it would enable us to learn from what happened to me, the things I did, the things I wish I could have done, and the most important lesson of that near-death experience in which I thought I would be seeing the bright lights and I would see angels singing hallelujah, welcoming me to heaven. But I'm sure I still have a purpose in life, and that's why I'm here. So with that, let me share with you this experience, and at the same time, let's derive some concepts which could potentially be in our licensure test. You could be laughing because, I'm already in a near-death experience and I'm still thinking about how can I share this to my students such that they would be able to learn something out of this, okay? That's me, your mentor, Ray. So let's begin and let's derive lessons along the way. So once again, I'm your fact check buddy at your service. So you might be wondering, we have a new set. I'm actually in one of the bedrooms in the house. I haven't had a haircut for a couple of months now. And of course, I'm still, for whatever reason there is, I'm having a phobic reaction, sort of like agoraphobia and social phobia or social anxiety disorders, you may call it, because I'm really having difficulty adjusting now to going out because of the experience I had, although I got the virus not from the outside or from going around, but somebody brought it right where I am. So this is my story. So how I get the virus, the very reason why I didn't have any idea that it was COVID, maybe a lot of you are thinking, how could he have missed it? I'm also a nurse. I'm an educator. I'm your mentor. I study all of this theoretically. And how could I have ever missed the beginning manifestations, or how could I ever be so careless that I did not protect myself? Truth of the matter is, I was so protective of myself. I'm only going out twice a week to the office, to the house. I have my staff, and I'm using a vehicle that has a part that's exclusively for me, and I don't open the divider between me and the driver. However, maybe because I trusted the people I'm with at home, that's the reason why. And another factor that we have to consider is that 3 to 4 times a year, I usually have an asthmatic attack. And these specific months are very predictable because my main trigger for my asthma would be a change in weather. That's the reason why whenever I travel, I have with me my EpiPen. And of course, I bring with me my levocetirizine or Benadryl, such that before I deplane, if there's going to be a change in weather, so I would have to take my medication before deplaning. Now, the same is true when I travel around the country here in the Philippines. And since March is actually the time in which there's going to be a shift from a little cold weather into the summer months in the country, so I was anticipating that probably I could have an asthma attack. Okay. And that's where my first mistake was. I was so accustomed about responding to the signs and symptoms that I feel with a preconceived idea that it is my asthma that's doing this to me. Okay, so at this point in time, I also have a full week. I have commitments with students to mentor, business partners to meet. I have speaking engagements in professional organizations. In fact, I have one here, the nursing profession in the global healthcare landscape. It was actually on that last day of the week, on a Friday, that I felt a little something is different. And then after that, okay, we were actually planning to have a summer beach party at the office. And that's why we were reserving a specific place. So we're off to a beach resort. And in fact, to prepare, we're having like a costume party on the beach. So here's one of our office mates. Okay. She's dressed as a mermaid. I had my costume, the octopus one. So we were so excited. And then on Saturday, I'm supposed to, because on a Thursday, I did have a mentoring for one of my students who's taking the test on the NCLEX. And then on a Saturday, I'm supposed to be having another class. However, it was the first time that I just felt so tired. And possibly I was telling my staff, maybe you gave me just too much for this week because I was, all around the place, all over the place from Monday to Friday and Saturday I have a class. It was the first time in my more than 25 years as an educator that I ever cut my class. I was doing lectures before with an IV fluid while running fevers. I never really cut my classes. It was the first time. It's because I just felt so weird. I was so tired. And in between like 1 to 2 hours, I will need to have power naps. I was trying to ward it off. And then when I wasn't able to do that after lunch, I gave my students an early break. I took a nap in my office. Then my secretary asked me, "Sir, is there something wrong with you?" Because they seldom see me on the couch taking a power nap. It's the first time that they saw me do that in the office within this period of time. So I really can't explain what happened to me. What I remember was I didn't have any exposure because I was just from the house to the office and doing all my classes, my engagements, and my meetings via Zoom. I didn't get a virus that way. So, of course, I know I can control myself, but I cannot control the movement of the people around me. And so what happened was, before I tell you what happened, how I got the virus, okay, so let's move on. When you are a person who is under investigation, you're called a suspect, okay, according to the case definitions of the World Health Organization. You're considered as a probable case when the SARS-CoV test is inconclusive or not available. And you are considered confirmed when your laboratory test or your PCR test of COVID-19 is positive. And I didn't have the test initially. So I didn't have any idea that I'm having the symptoms, okay? So on a Saturday, I cut my class. From the office, I went straight to my bedroom. I asked my house staff, one of my house staff, to just bring me food because I wanted to catch on sleep. Maybe I'm just lacking sleep. The whole of Sunday did not go out of my room. And then Monday, I have body aches all over. And Sunday night, I was starting to run a fever as high as 38.9. And then I asked my staff, my house staff, if you could give me a tepid sponge bath, okay. And then I took paracetamol for my fever. And then that's the time on Tuesday when I'm beginning to feel that I'm not getting any better. So I asked one of those who visited me within the week if there was any exposure on his end. And he responded by showing me that he's already taking medications. And I said, okay, so could I have prescriptions also so that I can take this medication? So it's actually steroid, azithromycin, and paracetamol. And after like 2 days, I was feeling better. So I thought, okay, this could just be a mild symptom, so I can get through it. I'll just finish my 14-day quarantine. However, on That was Tuesday. On Wednesday, I felt that I was up and about. On Thursday of that week, I was doing my usual thing, eating my breakfast, talking over the phone. So I was monitoring now my oxygen saturation using my pulse oximeter. And in the morning, I had 94 to 95. So normal is 95 and above. In the late afternoon, I had 92 to 93. And then at 9 p.m., I thought this was broken because I was trying to get my oxygen saturation before I go to sleep, and it was registering at 84. I know that 85, anything below 85 is critical. And for somebody who's having below 90 oxygen saturation, you are supposed to be on your way to the hospital. And I'm still at home. It's already nighttime. And so I consulted a private practitioner who gave me the prescriptions for the medications, and she told me if I could get an oxygen. So I asked my driver and one of my house staff to go around and look for one. They weren't able to get anything. And then this is where the problem is, because the private practitioner kept on asking me, are you having difficulty breathing? Are you having difficulty breathing? We weren't on the same level of describing what I feel. I was trying to tell him, no, it's not difficult for me to breathe, but there are episodes in which I catch my breath and then recover. So, does that really, can that be accurately described as difficulty of breathing? So she was asking about difficulty of breathing. I am describing shortness of breath. So we were not on the same boat. And then she said, well, if that's the case, you can just turn on the fan, okay, have a complete bed rest for the night, and maybe you could have the oxygen tank tomorrow. And I was saying, like, but I don't feel comfortable having those interventions just like that, because I just stay at home alone. I just have my three house staff and my driver. They don't know anything about what to do with me just in case I pass out, and they don't know what to do next. And so, since I'm still conscious, I called my friend, a very close friend, who's a classmate when we're doing our doctorate degrees, and she told me that, no, you're catching your breath. I think you have to go to the hospital. And right then and there, I called my sister. I said, I wanted to have myself admitted so that it's going to be easy for me, so that everything that I need will be there. Don't have to worry about buying the oxygen tank. So I will have my medications there, all the diagnostic tests. And then my sister started by telling me, okay, so you call the ambulance. I said, the reason why I called you is that you have to call the ambulance for me, because I will have to prepare the things that I will bring to the hospital. And they said, okay, okay, okay. And then, do you have your driver with you? Maybe he could just bring you to the hospital. I said, oh, he's out because he's looking for the oxygen tank. And then my sister said, so possibly you can call him and ask him to come back. And I said, can you not do that for me? So we're actually passing on the buck to each other, because we were on a panic mode. We don't know what to do. Fortunately, my friends are conscious, alert, and their sanity is intact. So the moment that they felt I have COVID, they didn't have any choice but to tell me, okay, we're going to try our best to look for a room in a hospital. And that was the time that cases are surging. And actually, there are no vacant hospital beds. You have to go outskirts of Manila to get a hospital bed. ICUs are full. Patients are intense. The queue of waiting patients in their cars are very, very long. But miracle of miracles, my friends never let me down. So, how did I get? This is the puzzle actually for them. They know that I'm very careful. How did I get the virus? It's through secondary exposure. Somebody who got it from somewhere else, probably in the gym, possibly in the mall, and then came to visit, had dinner, joining me for dinner. We were talking together. I was so trusting, okay, because apparently the person looks healthy. And never had I thought that he will not be conscious of the activities he had. And Not until I asked him if he was exposed a few days after I had the symptoms, like 3 or 4 days after I had the symptoms, did he just give me a hint that it could potentially be COVID. So I took it upon myself to have myself tested, to bring myself to a hospital, ask my friends to help me out, and ask my sister to take charge. So if we're going to do a little backtrack, the natural reservoir of SARS-CoV-2 seems to be bats. I didn't have an exposure to bats, okay? Nor did I play with bats. But of course, sometimes around the house, okay, the garden, you don't know whether those are birds or bats at night. Um, could those be the potential source of the infection? Now, if that's going to be the theory, then it should not have just been me, because my two of my house staff tend to the garden and the poolside, so they could have been more exposed than I was. So I don't think that the bat theory, okay, could suffice to explain where I got the virus. Okay, so the coronavirus looks like this. It has a spike protein, okay, and the cells in the human body has a receptor binding protein that binds with the spike. So this is the target of our antibodies or immune globulin. They move themselves deep, okay, into the receptor binding protein, and eventually, okay, when they get attached to the spike protein, the immunoglobulins or antibody could cause the destruction of the virus. So that's the very essence of developing your antibodies or immunoglobulins. So immunoglobulins are for antibodies, here's a functional concept, are produced by plasma cells or the white blood cells, which binds to bacteria and viruses, causing their destruction. So your immunoglobulins or antibodies actually function as your body's defense. Okay, now there are several types of immunoglobulins. We have immunoglobulin A, which is found on our body surface, and it protects the mucosal surface. So if the skin is the first line of defense among your immunoglobulins, immunoglobulin A could actually enhance the function of the skin as the first line of defense. Immunoglobulin G is found in body fluids. It's the smallest and most common. It can cross the placenta, and it fights bacterial and viral infections. So it's not surprising to see your immunoglobulin G increase when you have both bacterial or viral infections. Immunoglobulin M is found in the blood and body and lymph fluids. It's first produced in response to infection. So this is the first that elevates when you develop an infection. And then immunoglobulin E is found in the lungs, the skin, and mucous membranes. It's responsible, and it's elevated when you have an allergic reaction, right? For Filipinos, we call it galis. Pagmayaman allergy. Okay, that's just a Filipino joke. IgD is found in small amounts in the tissues of the belly or chest, and up to now, it has undefined functions. Now, why did I miss on my diagnosis? Why didn't I consider going to the hospital, getting a swab like 3 days after? Because it's not recommended for you to do so. Like the appropriate time when you should be having your swab would be between day 5 or day 7 of the infection. Plus the very fact that I didn't have the usual symptoms. My sense of a smell was intact. That's why I keep on smelling my perfume if I smell good. So I was telling to myself, this is not COVID, even if, I feel a little bit off for a couple of days when I was having fatigability. Okay. But it never crossed my mind that it was COVID because I didn't lost my sense of smell. I did not lost my sense of taste. I was not running a fever. I didn't have sore throat. All I had was that I felt so tired. And I was rationalizing that it could be because I had like the whole week full of engagements. So I was just telling maybe this is one of those weeks that I'm really so tired, and maybe it could be age related. However, when I developed fever, it was so high. That was the time that I confronted, okay, one of the members of the household who could potentially be exposed somewhere else in the gym or in the mall, get the virus and brought it inside the house. And, okay, let's go over this. Let's turn this into a question. What if you have a question that goes this way? Which of the following signs and symptoms can occur with COVID-19? Okay, fever. I had this, but I had it late. Cough. What is really puzzling is that most of the literatures would say dry cough. That's one of the reasons why I did not suspect it's COVID, because my cough is productive. But eventually they corrected the literature and they said from dry progressing to productive cough. Okay, so I had that. Fatigue, I had fatigue. That was the first symptom that I felt. So it does not necessarily mean that when you get the virus, you will go through these signs and symptoms in order. No, you could have just one, two, or just one among these symptoms, or even none at all, in which case you are asymptomatic. Okay, in Filipinos, we call it asymptopangit. Okay, so sore throat, yes, it's a symptom, but I didn't have it. Diarrhea, it is a symptom, but I didn't have it. But when I was in the hospital, what I felt is actually bloating. It's sort of, when I had the virus, my body system, some of my body system relaxed. Okay, and then lack of smell or anosmia. Yes, it's a symptom, but I did not have it. Lack of taste, it's a symptom, but I did not have it. So if we're going to summarize all the signs and symptoms, you could have fever, cough, fatigue, which occurs in 44 to 7% of 44 to 77% of those who get the virus. I have to emphasize that because that's the outstanding manifestation for me. Anorexia, shortness of breath, sore throat, headache, nausea, vomiting, diarrhea, anosmia, adeusia, which is absence or lack of taste. And then I had this symptom, I think it was on the Thursday, the night before I spoke at an event of a chapter of the Philippine Nurses Association, when I had hiccups all throughout the night. I don't know why, okay? And that's the only time that I had hiccups for the longest time. But since I am really, really dead tired and quite sleepy, I didn't really mind it. Okay, now, so according to the World Health Organization, we can classify COVID-19 pneumonia as either mild, moderate, severe, and critical. I had critical COVID pneumonia. So it's like the end stage of the classification. So we can say mild when you have symptoms but without evidence of pneumonia or no evidence of hypoxia, which means the oxygen saturation could be high. But, okay, always remember that there's also what we call happy hypoxic people. What does that mean? Some patients could be laughing. They wouldn't tell you that they feel anything because they're not feeling anything. In fact, that's why it's called happy hypoxia, okay, or happy hypoxemia. It's because not until you check their oxygen saturation with your pulse oximeter, then you wouldn't have any idea at all. Okay, so for mild pneumonia, okay, or mild COVID, the treatment is just to isolate the client. And then symptomatic treatment. What does that mean? Treat the symptoms. So if the patient's having fever, then you have to give paracetamol. Now, why are antibiotics not indicated for mild COVID pneumonia? Because of the potential development of resistance. Okay? And if that develops, it will be more difficult to contain the bacteria or the virus that's causing the pneumonia if we are giving medications in anticipation, okay, of the progress of the disease. So no antibiotics are indicated for mild pneumonia. For moderate disease or moderate pneumonia, so the patient will manifest typical manifestations of pneumonia. You have fever, cough, dyspnea, fast breathing. However, the patient will not have signs of severe pneumonia. And the oxygen saturation is usually more than 90% on room air. So once again, the treatment would be to isolate the patient, provide symptomatic treatment, monitor, and this time for moderate pneumonia, if the patient is beginning to develop bacterial infection, antibiotics could already be given. And then for severe pneumonia, Okay, once again, the patient will have the signs and symptoms of pneumonia like fever, cough, dyspnea, and fast breathing, plus any one of these symptoms: respiratory rate of equal to or more than 30, severe respiratory distress manifested by labored breathing, intercostal retractions, okay, shortness of breath, and the oxygen saturation at this point in time falls below 90% on room air. This is the patient who should be on the way to the hospital. Once that oxygen saturation drops, the patient has to be on the way to the hospital. That's why I was thinking, what if for an area where there have been like several positive COVID cases, they should have in their home kit a pulse oximeter so that they would know when they should be bringing themselves to the hospital. Because if I am not a healthcare worker, if I'm not a nurse, I would not know how essential is having a pulse oximeter and to monitor oneself. Well, some they are told just to get themselves a pulse oximeter, but they were never told about how they would interpret the findings. What do they do if they get to see a value less than that? What is acceptable? What is appropriate? Or what is compatible with life and which one is incompatible with life? I think patients have to be informed. So once again, when a patient already has severe disease or pneumonia, the priority would be immediate oxygen. But do not misconstrue oxygen as a cure. So oxygen is a treatment, it's not a cure. What's the difference? A treatment would address the symptom. So oxygen will help you breathe easily, normally, but it does not target the main cause of the disease. And the main cause of the disease is the coronavirus. That's why immediate oxygen should be there just to enable the patient to function properly, and then the patient needs to be monitored. Okay, what happened to me was, I think, a couple of days after my exposure, I developed severe disease, but I never thought it was due to COVID. I thought it was due to my asthma. And usually I just treat my asthma with, a glass of red wine, and then I sleep. Okay, and I set the temperature in my room at 18 degrees, okay, centigrade, and sleep over the entire day. The next day, then after that, I'd be okay. But that did not happen. In fact, I deteriorated. And from somebody who was walking around in the morning of that fateful day, they decided to have myself admitted to the hospital, I have to ask two of my house staff to assist me from navigating 2 flights of stairs, going down, and then going to the vehicle that will bring me to the hospital. Okay? So, to navigate where my room is at the second floor of the house would just require me 2 flights of stairs, and I had difficulty. I my sister who actually saw me said, I am like a tissue paper. That's how weak looking I am. I'm really having difficulty walking. And to my surprise, why did that happen? Where in fact, in the morning of the same day, I was up and about. I don't know. And then we have critical disease, acute respiratory distress syndrome, or ARDS. This is the one that I had. Okay. Now, the criteria, the onset would be within 1 week of pneumonia, and then the x-ray would show opacities due to the presence of infiltration and definitely very severe oxygen impairments. In fact, I had hypoxemic respiratory failure. Okay, so in essence, the oxygen in my blood is already running low. And the treatment of choice definitely is invasive mechanical ventilation. But was I intubated? That's one thing that I'd like to share with you guys. Why the treatment options, even if I had acute respiratory distress syndrome, did not proceed as what the algorithm says. And it's because of some decisions I made while lying on my sick bed. And of course, another form of critical disease would be sepsis, in which there's going to be multi-organ dysfunction. The patient will have decreased level of consciousness, increased heart rate, low oxygen saturation, decreased urine output, which could mean the shock is developing, and then acidosis and hyperbilirubinemia or jaundice, in which case the patient is treated once again with oxygen and fluids. And the patient may have the potential to develop septic shock, in which it is manifested by persistent hypotension despite administration of fluids or volume resuscitation. And it would require the administration of vasopressors like dopamine, okay, to maintain the mean arterial pressure that's equal to or more than 65. Okay, so once again, the primary treatment for septic shock would be administration of crystalloids. When I say crystalloids, you have your normal saline solution or lactated Ringer solution. They would usually give 250 to 500 ml rapid bolus in 15 to 30 minutes just to jumpstart volume resuscitation. Well, I did not have that. What I had is actually acute respiratory distress syndrome because I'm asthmatic. I have comorbidity. Diabetes runs in my family. When I was 30, my cardiologist gave me my maintenance antihypertensive because, once again, hypertension runs in the family. Okay, so if I will have to suggest for those who are having like asymptomatic or mild COVID pneumonia at home and they're doing home management, what are the essential things that you have to have? I believe you have to have your thermometer, you have to monitor your temperature, and of course, your pulse oximeter that could tell you when would you need to go to the hospital. That's when your oxygen saturation falls below 90%. Okay, so let me share with you some of the things that I got from my readings. Normal, of course, when it comes to oxygen saturation is 95 to 100% at room air. Now, when will you need to monitor yourself? Okay, when you are recuperating from COVID, which means after you've recovered from COVID and you're already at home, for as long as your oxygen saturation will not fall below 90, my doctor advised me that it's all right. If it falls between 91 to 94, you don't need oxygen. You just have to monitor, making sure that you don't fall below 90. And if that happens, then that's the time you will need to have your oxygen. And once again, get yourself to the hospital the soonest way possible time you can. Now, the critical level is 85 and below, which means you are in a very life-threatening situation. That's what happened to me, okay? So on the day I got myself to the hospital, my oxygen saturation, well, I took it in my room, is 84. In fact, I was telling my house staff, I think this is broken. Let me try it on you. And when I got this oxygen saturation, it was 97. I put it on my fingers, it was 84. So I said, something's wrong. This is below 85. So I called a friend to help me out with my hospitalization. So don't get yourself confused. If the patient is already post-COVID and they're recuperating at home, 91 to 94, or any oxygen saturation that is above, okay, 90, okay, as advised by my doctor, is fine. That's when you are recuperating. But when you are just beginning, okay, to develop pneumonia, okay, you have to make sure that you have a ready plan to get yourself to the nearest hospital. Or it would be a bonus if you go to a hospital that knows your history. On my end, I've been a client of that hospital since more than 10 years ago. The reason why I always get myself confined at the hospital because most of the administrators are my friends and my doctor is a friend. And the good thing about it is that sometimes I get free services And of course, the disadvantage that when I get admitted, since most of the nurses there have been my students, they would usually say, Ray, what happened to you? So I tell my story for the morning shift. Then here comes the afternoon shift asking me, Sir Ray, what happened to you? So I have to go back again and tell them my story. And when the evening shift comes, they would say, Sir Ray, what happened? So I keep on repeating and repeating. And that would definitely put a toll on me, and especially it disrupts my sleep and my resting period. But just to show you why I opted to have myself admitted to that hospital, even if it's approximately an hour and a half away from where I live, well, it is different when you can openly collaborate with your healthcare providers. That spells the difference. Because if you collaborate, the communication is open, you honestly can tell that person, your healthcare providers, what's going on, and without the fear of the unknown, because you've been working with them for the longest time, then that's a plus. Okay? So let's try answering a sample question related to what I shared. This one thing I like with this. I share my experience, but we derive lessons from it. Some things that would enable you to prepare for tests. Okay? Let's begin. A client calls the nurse on the phone asking what needs to be done as her oxygen saturation is at 90%. What should the nurse tell the client? 1, seek hospital admission. 2, be on complete bed rest. 3, stay at home in an air-conditioned room. 4, turn on the hot water bath in the restroom and inhale the steam. I think option 4 is about when you're having phlegms. Now, in Ilocano, we call this suob. And a lot of people are saying suob is actually inhaling the mist or the vapor coming from hot water, that in which you would also place some mentholated medications, and then you inhale the mist. So they call it suob. But that's a more social way of doing it. When in our province, okay, in La Union, when you say suob, literally, suob is an Ilocano word meaning pinausukan, okay, or being steamed. Okay, in the province, they really set up, leaves and they medicinal leaves, and then they set it on fire, and then you're asked to inhale the smoke. So that's the concept of soup in the province. Now here in Manila, it became more social, okay, because some people are doing the soup using a rice cooker to boil water, and then they put the medicated cream or medication into that boiling thing, and then they inhale the mist. Okay, so that's soup. However, please note that soup is a form of treatment. It's not a cure. It will help relieve the symptoms, but it will not directly attack the virus. So I think we have to be clear on that. So some people are just saying, well, I got well because I did soup. Maybe because you have a mild pneumonia. And the soup helped relieve the congestion in your lungs. But did it actually kill the virus? Nuh-uh. Okay? So stay at home in an air-conditioned room. You can do that if your oxygen saturation is above 90, not at 90. Complete bed rest also when your oxygen saturation is above 90. So the best answer is to seek hospital admission right away. Okay, so in COVID-19 patients, aggressive fluid resuscitation may worsen oxygenation. I had an experience in which, since I felt like I'm dehydrated, so they gave me a lot of supplements because I'm unable to eat in my first few days in the hospital. So I have a lot of IV fluids, and then eventually my doctor ordered like 40 milligrams furosemide, and it's because I'm beginning to feel crackles in my lungs. So there's now fluid accumulation, and fortunately I responded well. It helped prevent the buildup of fluids in my lungs, but it did not stop the pneumonia from progressing. Okay, so on my day 1 at the University Medical Center at the Del Cell Health Sciences Institute, you would notice the room is a little more spacious. It's only the room that's available for me. So, well, we have a ref where we have food. Of course, my personal staff, my Kuya Rodel, who is my yayo for the longest time, I think it's more than 15 years with us already. Okay. And of course, there's an area here okay, where he can hide himself, do his thing, eat his meal. So we're observing physical distancing. And in fact, since he is in a full PPE gear 24 hours a day, he's on triple mask, and then I don't allow him to hold anything that I use. So if I will have to discard something, I ask him to bring a plastic bag, and it's me that discards it. Okay. And that's the reason why he was able to keep himself COVID free, even if he stayed in my room 24 hours a day for 2 weeks. And he had several PCR tests and all turned negative. Okay. So, hallelujah. So that is in itself miracle. Okay. And then what's funny is that, they placed my father's name instead of my name. So Ricarte Aspiras Gapus. That's my father's, not me. Okay. Maybe they mixed it. Okay. Anyway, you don't have the junior, right? Okay. So the priority, this is the sad truth about COVID. The priority intervention in the management of COVID-19 is also the priority effect and psychosocial concern. What is that? Isolation. So the moment that you get your test result, or the moment that you have symptoms that are characteristics of the disease, okay, affect you, or you manifest this. So the first thing that you should do is to isolate the infection. We're not isolating the person, we're isolating the infection. But at the same time, it's also the priority effect. Because when you isolate yourself, you're all alone, you're doing everything to yourself. I'm just so lucky I have my Kuya Rodel with me. Okay? What happens is that eventually you get anxious, especially if you don't understand what's happening to your body. If you don't understand the interventions that are being done to you. If you don't know what the machines that they're bringing to your room are. And so when anxiety builds up, eventually go to panic mode. And then when you don't see yourself improving, there's a sense of hopelessness that could lead to depression. And these are the difficulties of a COVID patient. That's because more often than not, the priority intervention also causes the priority psychosocial concern, which is isolation. Now, it is recommended that even if you're staying in one room, you have to have at least 1 meter of distance in case of urgent interaction. And for suspected and confirmed cases, you have to apply or implement contact and droplet or airborne precautions. Now, there has been a lot of debate whether we need to apply droplet or airborne precautions. Now, what the WHO and the Centers for Disease Control is saying, but at the time when I did my research, is that primarily it is transmitted by droplet, but they are considering transmission by airborne aerosols. So if you talk about precautions, it has to be droplet precautions at this point in time. That is the primary isolation precautions that's indicated for this type of patients. Okay. For symptomatic patients, transmission-based precautions are discontinued 10 days after symptom onset. So if you had the symptoms on, for example, April 1, okay, on April 11, 10 days after, okay, plus 3 days without symptoms, okay, plus 3 days, 11 plus 3 days, April 14. So you have 14 days from the time of symptom onset, then you can stop implementing your transmission-based precautions, which means airborne or droplet precautions. However, you still have to adhere to basic protocols, okay? That's for symptomatic patients. Now, what about if you have asymptomatic patients? Transmission-based precautions are discontinued 10 days after a positive test. That's where the difference is. Take note. For symptomatic patients, we use the basis of the onset of symptoms to count 10 days. But for asymptomatic patients, we use as basis, okay, the time when the patient had a positive test. So if the patient felt the symptoms on April 1, okay, then had himself tested on April 2, and then the test result came in on April 3, count 10 days from April 3 onwards. It's not on the day that the patient had the symptom, okay, because a patient who is asymptomatic will definitely not manifest a symptom. So it's gonna be on the time that the patient obtain a positive test result. That's for asymptomatic patients. Once again, for asymptomatic patients, the basis is going to be the positive test. For symptomatic patients, the basis would be the onset of symptoms. Okay. So, what happened to me after that? Okay. The good thing about when I was admitted to the hospital is that I have friends, and in fact, before I even reached the hospital, as you could see in this text, okay, my friends telling me I already have a group of doctors, of course, thankful to Dr. Gary Carlos and Dr. Nicolette Alabado. Of course, Dr. Carlos is my lead pulmonologist. Dr. Alabado is an infectious disease expert. And of course, my attending physician, Dr. Dave Pagsihan. Okay, and then I was wheeled into the emergency room. If you would notice, I already have 93 oxygen saturation. Um, Here, I had 93, but okay, when I arrived at the emergency room, it was 86. But when I was at home, it was 84. And that's the reason why it's below the critical level of 85. That's the reason why it was already past 9 p.m. when I decided that I have to bring myself to the hospital. And then what's funny was that my sister's asking, okay, so what will I send you? Look at what's the first on my list. Eskinol, Eskinol and cotton balls. I said, ate, okay? And I said, the Oreo, it's not appropriate for me because my sugar is fluctuating. And then I said, I want fruits, I want seedless grapes, I want mangoes, and of course, watermelon, as well as pineapple chunks, okay? And then, of course, I requested for fried chicken. That's me, the kid in me. Okay, and here comes the positive test. So my PCR test result actually turned out positive. So immediately, even before I got my test results, based on my symptoms alone, my doctors initiated my treatment. So beginning with the administration of azithromycin, and then dexamethasone and remdesivir. Okay. They also asked me if I would want to sign an informed consent form for drugs that are used for with compassionate use permit, tocilizumab, and I immediately signed it because I entrusted my life to my doctors. So what then was my diagnosis or clinical impression when I was admitted to the emergency room? Okay, let's take a look at my laboratory results. Of course, my potassium 3.6, it's normal. Normal is 3.5 to 5.3. My creatinine is actually a little high. It's at 73.9. Normal should have been less than 10. And then my ALT is 134. Normal is 7 to 55. Why would they need to get my ALT? Because your tocilizumab, okay, could potentially cause hepatotoxicity. That's why they have to check for my ALT. But my endocrinologist gave a clearance saying that the slight elevation in ALT could have been associated with my blood sugar fluctuation. So they agreed that it's appropriate for me to receive tocilizumab. And then C-reactive protein, 70.3. Normal is actually less than 10. That's also high. Ddimer is more than 500. It's 578. Now, my Ddimer eventually actually went up to more than 3,000. Okay, where in fact, according to this laboratory result, the normal is less than 500, but according to what I've read, it has to be even less than 250. So, what are the implications of this? Your D-dimer is a blood test that is blood test used to determine risk for clot formation. So, if my D-dimer is now in the thousands, I'm at risk for clot formation. That's the reason why initially my doctors, okay, were giving me enoxaparin sodium or Lovenox once a day in the morning. And then they doubled it when my D-dimer went up to more than 3,000. And then the C-reactive protein test is used to detect inflammation, and the normal is less than 10, and I had more than 70. So it could be that I'm having now inflammatory reactions due to the presence and multiplication of the virus in the body. So I was just hoping that my kidneys would be healthy, my heart would be healthy, and the heavens heard my prayers. So had it been that my other organs weren't as healthy as they were during the peak of the infection, I would not have made it, because my body could have gone through multiple organ dysfunction. And I'm thankful I did not develop that complication. And then alanine aminotransferase is actually checked before the administration of tocilizumab. Okay. So, sorry, normal for alanine aminotransferase should be, sorry for that, should be 7 to 55. Okay. That's a typo error. Okay, so if you would see, my D-dimer is 578. My C-reactive protein, which is normally less than 10, is 70. Okay, so if you would notice, also in my ventilator, it's administering 40 liters per minute. Wow. And I remember a friend asking me, how does that feel? Um, Honestly, when I was already recovering, 5 liters per minute really is already irritating to the nose. I can't fathom and imagine how was I able to tolerate 40 liters per minute. And I needed the 40 liters per minute for my oxygen saturation to reach normal, like above 95. And sometimes, the moment I was admitted, I was already beginning my deep breathing exercises for 10 minutes every hour. As they say, rehabilitation begins on admission. And the primary rehabilitator is the patient. But again, I ask you, how many patients understand what's happening to themselves and know what they're supposed to be doing to help their healthcare providers? That's where the problem is. Sometimes we are not empowered. Information from social media and televisions and radios are confusing. The informations could be culled from literatures, but they are not reflective of the real life needs of patients. And that's the reason why I'm sharing my personal experience with you, so that you get at least an idea of what should be done when things don't go on your way. It happened to me, not once, but twice. I was in that situation when I was ready to face the bright light, not once, but twice. Okay? So, the diagnosis: acute respiratory distress syndrome. And in adults with severe acute respiratory distress syndrome, prone ventilation for 12 to 16 hours per day is recommended. They say proning. This is where the term proning became popular. In fact, my nurses were telling me, sir, could you actually lie on prone for 8 hours? And I was saying, like, my God, I can't even tolerate it for 10 minutes. And they said, well, you have to try, because it's what keeps our patient breathing. It's what kept the breathing improvement of our patients. So I said, okay, let me try. But always remember this: you have to have honest and open communication with your healthcare providers, especially your nurses. If you cannot tolerate 12 to 16 hours right away, you can begin with 10 minutes, 20 minutes, 30 minutes. Okay, and when they say proning, the action is that it relieves pressure on the back part of the lung so that it enhances ventilation. But when you say proning, it's not literally just lying prone. If you can't tolerate proning or lying prone for the longest possible time that's required of you, you could just have yourself turn to both sides, okay, and change it every 1 to 2 hours. Then lie prone probably for 10 minutes every 1 to 2 hours until you are able to tolerate the prone position for the required number of hours per day. Okay? So I'm not saying that you have to do it right away. So in adult respiratory distress syndrome, invasive ventilation is preferred than high flow nasal oxygen. Invasive intubation means you have to be intubated. But the problem is, patients on ventilators are the most at risk for nosocomial infection. So if you have a question that would ask you, who among the following patient is most at risk for nosocomial infection? That's easy. Look for the patient with a ventilator. Now, I wasn't intubated. Why? Probably because the deep breathing I was doing from the time I was admitted on a regular basis for 10 minutes every hour kept my lungs responsive. So in fact, I asked my friend, how come I wasn't intubated when my diagnosis is critical COVID pneumonia? Like patients, usual patients with that diagnosis would usually be in the ICU. I wasn't in the ICU. I was in my private room. But of course, eventually my private room, okay, had all the huge equipment and machines that are found in the ICU. Okay. So, and my friend said, it's because the doctors are seeing improvement. And while you are on high flow nasal oxygen therapy, so there is marked improvement in your breathing. And what I usually do is that I respond to my body. I tell my doctors that I feel better with this level of oxygen. And then we compromise because one of my doctors would usually want me to decrease the oxygen levels at night so that eventually I get enough. Because when you're having more than 50% oxygen, eventually you can develop oxygen toxicity. And when you have oxygen toxicity, you'll have vertigo, nausea, decreased level of consciousness, okay? And then eventually, okay, it would be more difficult for your doctors to rehabilitate you. That's oxygen toxicity. And that occurs when you are having more than 50% oxygen. I was having what, like what? 80 to 100%, okay, at 40 liters per minute. Okay? So, what I told my doctors that I'm beginning to feel better, doctor, but if we're going to lower down the oxygen at night, I usually become anxious because the other night I became so anxious, I wasn't able to get a good night's rest. Okay? And that triggered tachypnea. So fast breathing, shallow breathing. And so we entered into an agreement. So my nurse would tell me, so Ray, so we will do your weaning in the morning. And when you're about to sleep, you just have to tell me, I'll enter your room. I'll put your high flow nasal oxygen into a higher level. That's a compromise because I don't want to be anxious in the middle of the night because I have this obsessive compulsive type of personality that I want to monitor, okay, all the figures that are being reflected in the monitor. And in fact, I have educated my Kuya Rodel, my personal assistant, to tell me through hand gestures, we call it scores, the numbers for this monitor and for that monitor, so that I can interpret it for myself. So I don't sleep at night. I monitor the values. And then I sleep when the nurse would usually have their rounds early in the morning up to midday. Okay, and then another nap after lunch. So that's how I did it. So I collaborated with my nurses. The line of communication is open, and I usually would tell my nurse, kindly ask my doctor if we can adjust this. And that's when we already created a formula. Like when there's an invasive procedure, like an injection, or when they're doing like hemodialysis, okay, my nurse would tell me, we will need to increase your oxygen level at least 30 minutes to an hour before your procedure. Because there was once a time that wasn't done, and all of a sudden, I had almost all of the nurses and the resident physicians right on my doorstep because my oxygen kept falling when I was having my hemodialysis. And in fact, my nurse was telling me, can you still cope with it? You just have to tell me if you can't, I can stop the treatment. And I said, yes, I can. Let me just do some deep breathing. And maybe after the treatment, it would go back to normal. And so it happened. So communication is usually the key. So the part of the brain that's responsible for controlling breathing is the pons, found in the brainstem. So when the pons is damaged, definitely the manifestation would be an impairment in the patient's breathing. So if you are given this question, therefore, which nursing diagnoses the highest priority for a client with bleeding affecting the part of the brain marked B in the diagram below? So this question is a little difficult because it's asking you to interpret and look at the drawing. And the one that's marked B is actually pertaining to your brain stem. Okay, so your brain stem contains your pons. Therefore, could it be ineffective airway clearance, ineffective breathing pattern, unilateral neglect, or impaired gas exchange? Impaired gas exchange could be manifested by abnormalities in your arterial blood gases, like an imbalance in the carbon dioxide and oxygen levels. We don't have that as the set of data. Understand the question. Unilateral neglect is when there is paralysis of half the body. That happens in stroke. We don't have that. Understand the question. And then we're left with one or two. When we say ineffective airway clearance, there's usually an obstruction in the airway. We don't have that too in this time of the question. But when you say ineffective breathing pattern, it has something to do with the control of the muscles for breathing. And that's actually the function of the one that's affected, as you will find in the illustration. Therefore, the best answer would be, mark B, supposed to be, ineffective breathing pattern. Sorry for that. Okay? Now, if you would notice, sorry for the misprint, this functional concept, oxygen supports combustion but is not flammable. This functional concept is very important when you are actually trying to think about the safety of the patient. Because oxygen supports combustion, it's not healthy that we have 100% oxygen in the atmosphere. That's the reason why we only have 21% oxygen in the atmosphere. Because if we have 100% oxygen in the atmosphere, sorry for that, okay, then everything around us will be burned. Because oxygen supports combustion, but it's not flammable. So here's a question. Which statement best describes oxygen? It is combustible but not explosive. It is both combustible and explosive. 3, it is not explosive and combustible. 4, it is combustible and minimally explosive. The best answer, it is combustible but not explosive. Now, there are several methods of oxygen delivery. So we have by nasal cannula if the flow is at 2 to 6 liters per minute, and if the FiO2 or fraction of inspired oxygen, okay, would be up to 40%. Now, you would notice that oxygen by nasal cannula is the first thing that they do when your oxygen level is not severely decreased. Okay, so if you just require like 2 to 6 liters per minute, then they give it to you by nasal cannula. Hudson's mask, okay, this is the one that we have in the drawing. Okay, when you need oxygen flow at 5 to 10 liters per minute and the fraction of inspired oxygen up to 60%. And then non-rebreather mask, the one that we have in the drawing too, okay? When you need 10 to 15 liters per minute and you need fraction of inspired oxygen up to 90 to 100%, and then high flow nasal cannula if the flow that you need would be 40 to 60 liters per minute and the fraction of inspired oxygen at 100%. Therefore, you would see that this is a range. If you need a lower flow, then it's by nasal cannula. Need the higher one, your Hudson's oxygen mask, then non-rebreather mask, and then high flow nasal cannula. Okay, so oxygen via nasal cannula is the most comfortable and least intrusive method of oxygen administration. Using that concept now, let's answer this question. Which of the following methods of administering oxygen is most comfortable for a client that requires 4 liters per minute? So once again, if you say 4 liters per minute, we go back to this. So it falls into this category. 2 to 6 liters per minute being administered through nasal cannula. So the answer is number 1. Nasal cannula. Okay, high flow nasal cannula. Well, that's what I had actually. Was connected to a ventilator with a high flow nasal cannula because I needed at that time 80 to 100% FiO2 and 40 liters per minute. Okay, so your non-rebreather mask would be for 10 to 15 liters per minute, and your Hudson's oxygen mask for 5 to 10 liters per minute. Okay, here's another question. When monitoring a client who has respiratory acidosis, a nurse would expect which of the following are their blood gas levels. Now, in our channel, we have a video that would help you do the ABG interpretation using the RAMS method. Remember RAMS method? For respiratory, you have alternate direction of arrows. For metabolic disorders, same direction of arrows. So in respiratory disorders, usually you have alternate direction of arrows. Say RAMS, respiratory, alternate direction of arrows, metabolic, same direction of arrows. So all you have to check when you have a respiratory disorder is take a look at the pH. If it is acidosis, eventually the pH could be low and the carbon dioxide could be high. The normal pH is 735 to 7.45. Okay, the normal CO2 is 35 to 45. So you would notice that the pH could be less than 7.35, and you have options 2 and 4 for that. And the CO2 could be above, okay, 35 to 45. And once again, you only have option 2 for that. So the correct answer is number 2. Okay, so let's take a look at this. So remember, when a client is using the non-rebreathing mask, the client must partially deflate the reservoir bag during inspiration. What do you mean by deflate? Okay, it's where you eat. Of course, that's a joke. You eat on deflate, okay, and deflate is on the table, okay. So you deflate it a bit, okay, or the high oxygen concentration will not be achieved, and the mask will provide a flow meter. Okay, so when you're using your Hudson's mask, face mask, okay, oxygen mask, okay, there's usually an exhalation port, okay, that would allow, okay, the unilateral flow of gas, okay. So test alert, flow rates of 1 to 4 liters per minute are used with nasal cannula equating to a concentration of approximately 24 to 40% oxygen. Flow rates of up to 6 liters can be given, but this will often cause nasal dryness and can be uncomfortable for clients. I agree. Imagine I have like 40 liters per minute, and eventually I had that for 2 weeks. And when I cleaned my nose, wow, I had like 1 centimeter of dried mucus. For pediatric patients, maximum flow of 2 liters per minute in infants and children under 2 years of age, and 4 liters per minute for children over 2 years of age. So here's a functional concept. When using high flow nasal oxygen or HFNO and during intubation, you need to apply airborne precautions. In adults with severe acute respiratory distress syndrome, prone ventilation for 12 to 16 hours per day is recommended. And this is my first night at the De La Salle University Medical Center. You would notice I just have an infusion set and of course my high flow nasal oxygen ventilator. Those are just the 2 machines inside my room. Then eventually they add up a lot of things that really crowded my room. So that's me. I am doing my proning regularly. Okay. And then you would see here, I already have the dialysis machine until all the equipment really crowded my room. Okay. It was very difficult to walk through in between my bed and those equipment because of the wires. Okay, so let's try answering a simple question. Which position is best for a client with severe critical COVID-19 pneumonia? Is it 1, supine, 2, prone, 3, semi-Fowler, 4, standing? Definitely proning for 12 to 16 hours. Now, let's take a look at ventilators. What if during the test, you're asked questions related to ventilators? So here are some of my pointers on ventilators. Let's get through it. The first functional concept, when checking the ventilator settings, the first parameter to be chosen is the ventilator mode. Okay? Now, ventilators usually work by helping people breathe when they can breathe on their own. Now, take note, ventilators are not considered as a cure for COVID. Okay, it would just help the patient survive. So it's one of the treatment that is bundled with medications. Okay, so your ventilator pushes oxygen into the lungs through your oxygen delivery system. Okay, through a hose. Okay, so during the inhalation phase, the pump pushes air into the patient, and of course, the valve that facilitates the exit of air from the patient is closed. Okay, this point. So the valve that facilitates the entry of air is the one that's open. Now, what happens during the exhalation phase? Okay, as the patient breathes out, the valve that pushes air closes, and then the valve that facilitates the exit of air from the patient opens. So it's just a closed open mechanism. Okay. Now, if you talk about mode of ventilation, you have your volume control mode. It involves the delivery of preset of volume of air, called the tidal volume, to the patient. Now, when you say the tidal volume is the amount of air that goes in and out of the lungs with each breath, it's approximately 400 to 80 ml. Now, your volume controlled mode is indicated for clients like me who had your adult respiratory distress syndrome. We also have pressure controlled mode that involves the delivery of preset pressure to the patient. It's indicated for neonates. Okay, now there are 4 basic modes of the ventilator setting. Let's go through this and let's slow down a bit. You have your assist control. It's used for patients who need most ventilatory support. You see this in patients in the ICU. And with this kind of ventilator setting, the patient will have a set respiratory rate. Synchronized intermittent mandatory ventilation, or SIMV, is used for patients who are post-op. Okay, patients will also have a set respiratory rate, but the patient can breathe independently. Okay, TV will be inhaled by the patient independently. It's not the television set. Okay. TV would be your tidal volume. So in which case, in SIMV, you have a support from the ventilator. At the same time, the patient can breathe independently. And it's the patient who breathes in the tidal volume. Your airway pressure release ventilation, APRV, is used for patients with ARDS, and this time the patient can breathe spontaneously, like what I had. And then pressure support is used for weaning a patient from a ventilator, but this may lead to poor ventilation and potential respiratory acidosis. So, what are some terminologies that we need to be familiar with? You have FiO2, fraction of inspired oxygen. It refers to how much oxygen the patient is receiving. It is the amount of oxygen required by the patient to maintain appropriate oxygen levels in the blood. So below 0.5 or 50% is appropriate to prevent oxygen toxicity. In my case, I had as high as 80 to 100%. That's why my pulmonologist keeps on telling me, Ray, we need to lower down your FiO2, okay? And initially, I was a little aghast or fearful about lowering the oxygen, especially at night. But eventually, when things got better, we're able to do it. Then we have your PEEP, positive and expiratory pressure. It's the amount of pressure at the alveoli at the end of expiration, and this facilitates gas exchange, okay? So the normal is 5 to 10 centimeter water. Rate, of course, would be your respiratory rate, and the normal for adult patients would be 12 to 18 per minute. When I was having adult respiratory distress syndrome, I was having more than 30 breaths per minute. So patients with ARDS are placed on ventilators, and so they're placed on ventilators, they are at risk for nosocomial infection. Patients with ARDS are placed on airway pressure release ventilation, or APRV. And in this type of ventilation setting, the patient can still breathe spontaneously. So airway pressure release ventilation makes the expiratory phase longer than the inspiratory phase, and this is to prevent atelectasis, okay? So it's like asking the patient to make a whistle. So it prolongs the expiratory phase, like, okay? So now let me differentiate positive pressure ventilators from negative pressure ventilators. Your positive pressure ventilators require an artificial airway, meaning it needs your endotracheal or tracheostomy tube. You need to be intubated. So this type of ventilators will use positive pressure to force gas into the client's lungs. So it's as if your oxygen is being pushed inside your lungs. That's your positive pressure ventilators. Your negative pressure ventilators act from the outside. It's like your body is enclosed from the outside, and the negative pressure will create a vacuum that will suck the chest wall out to expand. And when the chest wall expands, air gets inside. So it's like the use of hyperbaric oxygen therapy, the one where Michael Jackson usually sleeps to optimize oxygenation of his body. I'm going to show you a picture later on. This is how it goes. Okay. So in negative pressure ventilators, okay, So the surrounding area in the body, okay, creates a vacuum that pulls out the chest wall, allowing now air to enter. So a positive pressure ventilator promotes lung expansion by delivering oxygen into the lungs. So here are the types of positive pressure ventilators. Volume cycled ventilators, the principle is that delivers a preset tidal volume, then allows passive expiration. The same tidal volume is delivered regardless of the amount of airway resistance. And this is indicated for ARDS and bronchospasm. So we also have pressure cycled ventilators that delivers a preset pressure. That's why it's called pressure, okay, cycled ventilators. Now, the advantage is that you have a decreased risk of lung damage from high inspiratory pressure. This is indicated for neonates. And for short-term therapy, those that require ventilators for less than 24 hours. And then you have your flow cycled ventilators that delivers oxygen until a preset flow rate is achieved during inspiration. And this is used for patients who are breathing spontaneously. Then you have time-cycled ventilators, deliver oxygenation at a preset time period, and it's used for sedated or paralyzed patients, like patients in the ICU. So a negative pressure ventilator promotes lung expansion by pulling out gas from the chamber where the client is lying. So an example of this would be your iron lung machine, the drinker respirator, and the chest shell. Another example is your hyperbaric oxygen therapy. So negative pressure is created by pulling out gas from the chamber. This results to lung expansion, which pulls air into the lungs. Okay. Now, this one thing I'd like to highlight. There are two types of ventilator alarms. You have the high pressure alarm and the low pressure alarm. Now, this is an important thing that you have to remember. What causes the high pressure alarm to sound? It's due to coughing of the patient, which means there's obstruction of the endotracheal tube. So what is your priority intervention when the high pressure alarm sounds? Suction the patient. Okay. What about when the low pressure alarm is the one that sounds? This could be due to disconnection or extubation, or there could be a leak, okay, somewhere along the way. So the priority is to reconnect or reintubate as necessary. Okay, so if there's an obstruction of the tube of the patient, it's going to be the high pressure alarm that sounds. If there's going to be extubation, it's going to be the low pressure alarm that sounds. So when the high pressure alarm of a ventilator sounds, it indicates obstruction. When the low pressure alarm of the ventilator sounds, it indicates disconnection or air leak. So let's try answering a simple question. Here we go. While providing nursing care to a client on a ventilator, the high pressure alarm sounds. Which of the following interventions is the priority of the nurse? So when it is the high pressure alarm that sounds, there's going to be an obstruction. So what do? Suction the client's air. What should be your priority nursing diagnosis? Well, that could be ineffective airway clearance. Okay, so the correct answer is number 3. So let's move on to another functional concept. VAP, or ventilator-associated pneumonia, is pneumonia that develops 48 hours or longer after ventilation is given by means of an endotracheal tube or tracheostomy. Patient position is associated with incidence of hospital-acquired pneumonia or ventilator-associated pneumonia. The incidence of hospital-acquired pneumonia is increased in supine patients than with semi-recumbent patients. Positioning a client is the highest priority in the prevention of hospital-acquired pneumonia and ventilator-associated pneumonia. Rinses with oral chlorhexidine, 5%, help prevent ICU-acquired hospital-acquired pneumonia. The use of oral or systemic antibiotics effectively reduces the incidence of ICU-acquired hospital-acquired pneumonia, but take note that the antibiotic should be given only when the patient is manifesting that they're developing pneumonia. It's not given as routine prophylaxis, as that could lead to the development of resistance. Now, if you talk about your ventilator-associated pneumonia, the diagnosis would depend on 3 things. There's the presence of pulmonary infection, which the patient would have fever, purulent secretions, leukocytosis, or increase in WBC. There's bacterial evidence of bacteriologic infection and radiologic suggestion of the infection, as evidenced by the presence of X-ray findings that reflects infiltration. Now, the use of ventilator, catheters, and central lines increase the risk for nosocomial infection. So if you'll be asked a question on the test, what is the priority nursing diagnosis for a patient with a catheter or central line? Risk for infection. What is the priority nursing diagnosis for a client on a ventilator? The answer, risk for infection. That's how you play with the functional concepts. Okay? So, ventilator-associated pneumonia is the most common infectious complication occurring in ICU patients. The oral pathogens of VAP may include Staphylococcus aureus, Streptococcus pneumoniae, Prevotella species, and Bacteroides fragilis. Now, what are the interventions? We call these interventions bundle of interventions. This bundle of interventions need to be um, performed as a bundle, which means it's more effective if you do all of this. Position, head of the bed elevated 30 to 45 degrees, oral care daily with chlorhexidine, prophylaxis for peptic ulcer disease and deep vein thrombosis. This is also the reason why I was given omeprazole to prevent peptic ulcer disease or stress ulcer. And I was given enoxaparin to prevent deep vein thrombosis because I was on bed. Because the moment I stand up and get out of bed, I usually have palpitation. And then my oxygen saturation goes down. Okay, sedation, vacations, and assessment for readiness to extubate. What do you mean by sedation, vacations? Sedation should never be done continuously. There has to be a time that would allow the patient to breathe on their own. Okay, so early placement of nasogastric tube and oral care with soft toothbrush and chlorhexidine rinses helps decrease the incidence of ventilator-associated pneumonia. And early extubation may decrease incidence of ventilator-associated pneumonia. That's the reason why when you keep the patient intubated for the longest time, eventually they develop pneumonia. That's why the doctors must be very, very, very careful and very anticipatory of the potential complication that could develop. So endotracheal cuff pressure should be monitored after intubation and every 4 hours thereafter. Endotracheal cuff pressure should be at least 20 to 30 centimeter water, as the pressure less than 20 centimeter water increases the risk of pneumonia. So it has to be 20 to 30 centimeter water. Okay. Daily sedation vacations allow for proper assessment of the client's readiness to be extubated and is most likely to help decrease the occurrence of ventilator-associated pneumonia. So here's a question. The newly licensed nurse is taking care of a COVID-19 patient. Which one is not an appropriate intervention? Not. We're looking for something that is false. Okay? Not a true statement. 1, keep the client on prone. 2, change positions necessary. 3, oral care with chlorhexidine. 4, administer sedatives continuously. There is, that statement became wrong. You have the word continuously. So the answer is number 4, because you have to have sedation, vacation on a daily basis. Okay? So to sum up what happened to me during my first few days in the hospital, here's a text from a friend. And he said, friend, I would translate it English. In your first week in the hospital, we're so worried because your pneumonia was so severe. Okay? And then I said, yes, I know. I felt it. I thought I wasn't able to make it. Okay? And my friend says, seems true, friend. Especially when the doctor said you're having cytokine storm. More on that, okay, as I continue to discuss my COVID experience and how I survived critical COVID pneumonia. So see you on part 2 of my COVID experience. I just hope that with what we have discussed, we are learning from my experience, both on the theoretical side of it and on the experiential side of it. But more so, I'd like you to learn about life in general. That whatever comes your way, you have to appreciate life as it comes. Welcome it, preserve it, work hard to be healthy. Well, cliche as they say, but health is wealth. When you are already on your sick bed, okay, your bank accounts don't matter, your big house don't matter, your cars don't matter. What matters the most is you hold on to dear life. And that is your primary responsibility. See you on part 2. So this is your fact check buddy, Ray Gapos at your service. And as I've been telling you a while back, even I was already on rehab, I wrote a book that is actually prophetic in nature to a certain extent. Okay, my co-author was the one who suggested um, the title. It's entitled COVID. So this has nothing to do with my experience, but COVID refers to collaborative virtual instructional designs for teaching and learning nursing. It's also available at the Amazon. Okay, so if you want to purchase and sponsor a nurse to become a better educator, here's the book. So it's made up of two parts. So part A is how to choose ubiquitous technology for teaching, learning, nursing. And part B, how to integrate social media and social networking sites in teaching and learning nursing. So you have examples for fundamentals of nursing, community health, maternal and child, mental health and psych nursing, medical surgical nursing. Okay, so all of these are the ones that I learned when I studied and took my master's in education, my postbaccalaureate certificate in e-learning design from Pennsylvania State University. So my co-author is the Honorable Glenda S. Arquiza, who is the chair of the Professional Regulation Commission Board of Nursing from August 23, 2017 to November 5, 2020. So my pleasure and honor to be a co-author of the chairman of the highest regulatory body for professional nursing. So once again, colleagues, thank you so much for the support. I miss you all, and I promise I'll do my videos regularly once again. This is Ray Gapos, your fact check buddy at your service. Don't forget also, I will be having my NLE Masterclass for the local licensure. Keep track of the announcements, and I would also be having, of course, my quick fix sessions. I have two quick fix sessions coming up, so be mindful of the announcements that we will do for that. So thank you so much, and once again, I will be at your service. Thank you, and may you all pass your test so we can all be successful. Disclaimer, this instructional tool is created to enable students to develop their test-taking skills. The question or questions and answer or answers contained in this instructional video were patterned after the official publicly accessed samples from the RN test plan of the National Council of State Boards of Nursing, or NCSBN. The discussions and rationale presented in the video are based on the lecturer's research and are meant to provide an explanation for the answer or answers to the question or questions that is or are presented. The lecturer makes no claim, directly, implied, or otherwise, that the rationale discussed is officially endorsed by NCSBN.